afternoon, and welcome to our 13th Annual Health Equity Symposium. I am the current president of Reede Scholars, Mary Fleming. The Health Equity Symposium serves as our signature event each year. But know that the Reede Scholars are busy at work throughout the year, conducting the business of the organization, meeting, fellowshipping, and presenting at annual meetings across the country. Each year, we also hold a leadership retreat in Atlanta where we are able to foster the development of the organization and strategically plan so that we can continue to work together collectively on health equity issues. We also host an interactive podcast, Reede Scholars Live, which can be found on YouTube and all of your common podcasting sites. On each episode, we talk health equity with different experts. We hold the annual Health Equity Symposium each year in conjunction with the DICP's annual Leadership and Faculty Development Program Conference and Minority Health Policy Annual Meeting. We use this time to not just discuss a topic that is of importance to vulnerable populations, but also to allow a platform for innovation and purpose that you can take back to your organizations and communities. Health Equity Symposium is designed to be a forum for discussion and exchange of ideas. I invite you to write down your questions for a robust Q&A in the chat later after the panelists have presented. I would also like to take a moment to thank our sponsors for this year, Harvard Medical School's Office for Diversity, Inclusion, and Community Partnership, CareQuest, DentaQuest, the Commonwealth Fund, the Children's Oral Health Institute, and Brush Time. I'm also super excited to thank the sponsor for this particular event, Howard University Hospital's Trauma Center, which is led by Reede Scholar and past president Mallory Williams. With that, I will turn it over to our moderator, Philip Murray. Philip is also a Reede Scholar, graduate of class of 2017, and is the current director of emergency psychiatry at UC Davis. He will introduce our panelists who will discuss this year's theme, Beyond Policing, Community, Violence, and Health Equity.
All right. Well, thank you so much, Dr. Fleming, for that introduction. Thank you all for attending today. I think we will have a very just spirited and robust discussion, as Dr. Fleming said. I'm Philip Murray. I will be the moderator for today. I'll say a few words and then I will introduce our amazing panelists. I feel like at every talk I have to say, I have no disclosures and my views are my own and do not represent my employer because I like being employed. But yes, so we will go from there. As far as today's topic, if you are in attendance, I'm going to assume that you have some interest in things such as health equity and social determinants of health. And I think you've also experienced that despite our beliefs that the moral imperative of equity and what's clinically appropriate driving decisions, that's not always the case. And so when it comes to a common language to discuss these things, to figure out not the what of what's going on, but more the why, we usually have to rely on evidence, experience, and things like that. So with today's topic, when it comes to early experiences in childhood, if you look back at things such as adverse childhood experiences and the ACE studies, it lets us know that these can have long-term implications. But those don't always take account of other types of experiences that people can have. Unfortunately, we have taken neighborhood violence as an ongoing truth that people deal with. But what about when structures that are supposed to keep us safe can be the sources of some of that aggression and violence? Unfortunately, over the past several years, this has become more of an issue that we have seen more of. And so it makes sense that we should contemplate some of the longer term consequences of these things. And so with our panelists, looking at it from the clinical perspectives, from the systems perspectives and community perspectives, we have experts who have real lived experience with these issues and solutions that hopefully we can all learn from and adapt to our particular situations. So to introduce our panelists, our first panelist will be Fatima Lauren Dreyer. She is currently a Posen Commonwealth Fund Fellow in Health Equity Leadership at Yale School of Management and the Executive Director of the Health Alliance for Violence Intervention. She is, sorry, I had to pause on the introduction. So the organization better known as HAVI, is a national network of hospital-based violence intervention programs serving violently injured patients by addressing the social determinants of health. Next, for our panelist will be Josefina Alvarado Mena. She's the Chief Executive Officer of Safe Passages, where she has grown the organization to a leading independent 501c3 and multi-service nonprofit organization that implements a continuum of programs that serve children and youth from birth through college and career. Safe Passages is currently funded by the California Reducing Disparities Project and the California Department of Public Health to address mental health disparities among African-American youth through the Law and Social Justice Life Coaching Program. And our final panelist, last but not least, Dr. Sarah Vinson, the founder and principal consultant of L'Oreal Forensics, associate professor of psychiatry and pediatrics at Morehouse School of Medicine, and adjunct faculty at Emory School of Medicine. Dr. Vinson is triple board certified in child and adolescent, adult, and forensic psychiatry. And she is a multidisciplinary forensic mental health expert consultation company grounded in relevant clinical experience and cultural and structural competency. She has provided direct patient care in juvenile and adult correctional facilities and served as a forensic mental health expert in family, civil, criminal, state, and federal courts. So our structure for the day is each panelist will give us a topic and give us a presentation on their areas of expertise, lasting about 15 to 20 minutes. Depending on how long it goes, we will take questions either after each individual presentation, or we will definitely take them at the end. So with that, I will leave it to our first panelist.
Hello there. Thank you so much, Philip, for that introduction, and just so appreciating the opportunity in the space. I'm going to share my slides, and let's see if I can get them to. Hopefully you all can see. So again, I lead the Health Alliance for Violence Intervention. We're a national organization working in over 85 cities in the United States to help stand up a model of care called hospital-based violence intervention by advancing hospital and community partnerships that provide equitable trauma-informed care to violently injured patients. We also consult with the Biden administration. We specifically work with the White House on standing up these programs across the country in hospitals that don't have them but have high need. And so it's really a pleasure to talk about community violence and trauma and its intersection with the criminal justice system. So just kind of a little level setting about interpersonal violence. You hear lots of different names and types of violence: community violence, partner violence, family violence, police violence. And in many communities, particularly in communities of color, we see poly-victimization, that we see that our patients are exposed to a range of violences, but we focus on gunshot wound victims, stab wound victims, but we know overall interpersonal violence leaves a lasting legacy, and the toll it takes on the physical, emotional, financial world of our patients extends beyond the acute incident, and we know influences their life course. And so we are really here to kind of contemplate and discuss those longer term impacts and the opportunities in the short term as well as the long term for support. Homicide is the leading cause of death for African-American boys and men, and the second leading cause for Latinos. What we understand from social network researchers is that community violence in particular tends to happen in very dense social networks, meaning that though there are peer groups that are connected to one another socially within a particular neighborhood. So there's been a prevailing idea that whole neighborhoods are violent and quote unquote bad, and these are often neighborhoods where there's significant structural violence, meaning that there's overwhelming divestment and neglect often across several generations, but that those who, there are particular individuals within those communities who may have been an increasing exposure to violence and may know each other. And over time, due to this significant neglect, perform or be connected, exposed to violence, are at elevated risk for violent injury. And that exposure then elevates their risk for re-injury. We find that 30 to 40% of those who enter our hospitals injured risk becoming re-injured. And of course, violence harms not only the victim, but also impacts the neighborhood. And so that exposure spreads like a contagion in neighborhoods. And there are epidemiologists who will often say violence behaves like a disease. I try to stick to the word a contagion to not kind of pathologize those who are victims to this kind of violence exposure, but we certainly see that sort of contagion behavior in the data. So talking a bit about the cycle of violence in neighborhoods, we often see that the trauma pervades the system. We have those who may experience an injury, or they might have been re-injured. As I mentioned, those who've been injured have elevated risk of re-injury. So the lower right-hand side, that could lead, unfortunately, they could pass away or imprisonment. Law enforcement are often involved in these cases, which exposure itself to law enforcement intervention increases harm. If they're treated in the hospital for their injuries, they may be discharged, and there's significant elevation in PTSD symptoms, acute stress. They may take it upon themselves to self-medicate. We see for many of our clients a desire because they feel unsafe. They may, for the first time, try to secure a weapon, and that increases law enforcement exposure. So this cycle continues. And what our work does is really work to interrupt this cycle. And we see it not only as an intervention, it's a secondary, perhaps tertiary intervention, but not only for the cycle, but also law enforcement exposure. We want to ensure that we are a buffer, so to speak, a health buffer that supports our patients. Philip mentioned adverse childhood experiences, and I think it's important to note here that experiencing violence is indeed an experience that adversely affects people, right? And that intergenerationally, this harm impacts communities. And so while we recognize that, particularly for complex and chronic trauma, symptoms, reactivity, and patterns vary through culture, may vary in populations. And so I think that for some, they might see subclinical presentations. We recognize that trauma is trauma, and that, and I'm looking forward to hearing our panelists talk about trauma in other ways, but I think it's critically important to recognize that this trauma is incredibly pervasive. For many of our clients, when they come, even though they've come to us because they've been violently injured, they might talk about exposures and traumas they had 10 years ago, 15 years ago, that are all coming back up because of the more recent case. And so we just recognize that there are many, many layers to the trauma that our patients are exposed to. This is a study, I just very quickly, one of our programs looked at the ACEs score of their clients. This is a Philadelphia program to just kind of recognize 100% of their patients, right, have over one, at least one incident within the ACEs checklist, but there's a vast majority of them are at around 4 or 5, right? So I think that's an important piece for us to just recognize. We mentioned the social determinants of health. I believe that many of you on the call understand that these are core foundations for a healthy community, and for our patients, access to housing, particularly access to school, safe passage to school, that these pro-social behaviors and structures are just so pervasively impacted in their experience of violence. And so our work is to attend to the social determinants of health in our work. And so our public health view recognizes that we want to have modifiable risk factors. We look at some of the social dynamics, and there are a range of strategies that also address this, but I'm going to focus on hospital-based violence intervention. But there are other models that look at these social dynamics. You may have heard of street interrupters or the cure violence model. There are others. We are broadly called community violence intervention. And again, we are one portion of that, but we often call this, in our advisement to the Biden White House, is to talk about the community violence intervention ecosystem and recognize that there are a number of access points for addressing those who are caught in these cycles of violence and need supports. It could be school-based programs, et cetera. But again, we're going to focus on hospital-based violence intervention. So very simply, gunshot wound victims enter the hospital and are provided, of course, an attending to their physical wounds. We then offer support through an interdisciplinary team, which includes a community health worker called a violence prevention professional. They're hired, they're sourced from the community, they're hired either by the hospital or there's a collaboration with a community organization, a community-based organization, but they have full access and meet the patient at bedside and begin to create a plan. They're consented into the program, and they are then offered a suite of services, and not only at bedside, but post-discharge. And what's critical is that we support the patient in developing a plan. We think about some of the more short-term needs around safety planning. If there is retaliation that might be planned in the moment, we want to talk about that, the crisis support that they might need. But again, I mentioned housing is a huge need for many of our patients. So we think about housing strategy. There are other needs around job placement and education. So our programs really do quite a bit. And we do so at a minimum of 6 months following discharging from the hospital. But many of our programs, we serve patients for over 2 years. The idea being that these complex cases and addressing some of these needs are so critical to the success, not only of the patients in neighborhoods, but also in addressing and interrupting larger cycles and patterns of violence within neighborhoods. So they help in driving down violence. I mentioned this interdisciplinary team, and something that the hobby has worked on is addressing the particular needs of the violence prevention professional. We were instrumental in having the violence prevention professional included in the National Uniform Claims Code. So there's a code, a reimbursable code for this professional. And recently, actually in 2021, we were able to clarify with CMS that Medicaid can indeed reimburse. Connecticut was the first state to adopt a policy for reimbursement for violence prevention professionals, and Illinois followed suit. We currently are working in about a dozen states that are interested in policies to reimburse for violence prevention professionals. So this is bringing in a whole new workforce to address community violence. We think it's incredibly powerful. Many of the workers who are in our programs throughout the country are formerly incarcerated, are themselves victims of violence, and provide incredible credibility and peer support support to patients. And so this model of bringing them into the health team has been really transformative. And I think an excellent example of all the different ways that racial equity and health equity shows up to allow community-sourced individuals, giving them the power to actually be architects of transformation in their own communities. We've had a few randomized controlled trials that demonstrate reductions in violent victimization. There's far more work that needs to be done and research that needs to be done, and we're fighting and have been successful in securing research funding to continue to understand community violence and modifiable risk factors. I wanted to be sure I concluded with talking about the impact of high law enforcement exposure and police violence. It is something that is, of course, an issue for this population, but I think especially so, more people are asking questions and paying attention to these dynamics, these everyday dynamics. And so there's a range of challenges with a high exposure to law enforcement as the prevailing intervention for violence. And what I mean by that is recognizing that there is an entire ecosystem, a health-focused ecosystem that cities can deploy to address the needs of those who've experienced high rates of trauma in neighborhoods as a preventative step, ensures that law enforcement aren't the only ones who are called when there are problems. And that, I think that the failure to put those in place means that law enforcement are overused, and that exposure in neighborhoods in and of itself provides harm. And so that coupled with a challenge that we see, it's quite pervasive for our patients, is the belief that when they are harmed, when they've been shot, that there's also some criminal involvement. So alongside their attending to their physical wounds and their mental health concerns, their safety concerns for the patient, the hospital staff and our interdisciplinary team also have to contend with law enforcement who want to interrogate patients, patients who've been shackled to hospital beds, oftentimes not preventing care teams from actually addressing the needs of patients. And our programs have been really instrumental in hospitals across the country, clarifying and revising policies about the role and the footprint of law enforcement within hospitals to ensure that we're attending to the patient's needs, because those are essential. That has been really powerful. They create, I think, opportunities to have conversations about trust, because there's just a low amount of trust in communities. Now, on the law enforcement side, we also want to acknowledge that there is, and we say this to our law enforcement partners, that there's a high rate of trauma and suicide in law enforcement populations as well. And that trauma has impact on the job. And so they too should be advocating for community and health-focused, public health-focused interventions, because it actually means that they're the last resort, right? Involving law enforcement should be a last resort, and not the call that happens in the beginning. That I think it really resonates. We've had, as we've fought for billions of dollars in federal funding for this work, so far we've secured a few billion, and I'm very proud of that advocacy work. We've received letters of support from law enforcement across the country because they see that there are tremendous challenges in trust within the community. They are deeply concerned about police violence, and recognize that partnership is the only path forward. And recognizing the leadership of public health, of community-based and community-derived strategies actually ensures that everyone is sitting at the table, sharing information and really working to transform communities. And so I believe that these have been very, very difficult conversations across the country, but there's real hope. We, through our work with the White House, have worked in a range of jurisdictions, including Minneapolis and St. Paul, to support communities that have been grieving and reeling from very high profile police shootings, and of course the loss of George Floyd nearly 2 years ago, actually 2 years ago this month, and working to put back together public trust in addressing needs that the community has every day. It's very, very difficult work. It's powerful work. And I think it is critical in our health equity vision that we include the brokering and the restoring of a kind of trust in community empowerment to address issues that are as life and death as violence is. And so I just want to thank you for the opportunity to share about this work. I'm very open to taking questions now. I'm happy to wait till the end of the panel. Thank you so much.
All right, I will say with the time we have time for a couple of quick questions, and then we can save the remainder for the Q&A afterwards. So for the audience members, chat has been disabled, but if you have any questions, you can submit them through the Q&A panel, and then we'll be able to see them and go from there. So I think while people are gathering their questions, I will ask, you mentioned that this work is occurring in 12 states currently. Is there anything that you can think of that is preventing the spread further, or would you say you guys are on pace in proportion to the funding that you have going on? Just trying to get an idea of some of the barriers of implementation.
We're in actually 85 cities, so we're in far more states. I was mentioning for this White House initiative specifically, we're in 16 jurisdictions. So the jurisdictions across the country that are we're contracted to support included Minneapolis and St. Paul. But it's a great question, Philip. I would say there are political determinants of health, and I believe that we've really worked to articulate a pathway for bipartisan support. So as I mentioned that we're in 12 states running, this is the 12 states. So we're working in a dozen states on Medicaid bills to reimburse for community violence intervention workers, the violence prevention professionals. And in those states, the states in which we've been successful, we've received Republican and Democratic support. And that takes a lot of work, really educating people about the power of this work. And we need to continue to do that, right, to ensure that there's access. In the South, we have found just a few years ago that we only had one program. And over the last, I would say 4 years, we've seen a significant increase in interest. So our programs are launching in Alabama, in Texas, in areas in which the electorate is dominated by Republicans who, and these are states that don't have, certainly Georgia, don't have Medicaid expansion, but are nonetheless interested and have enough will to begin the process. And we want to bring people along and share, because violence during COVID, I should have mentioned this, violence during COVID spiked significantly. And we saw in some communities, 60% increase in victimization. I was just actually at Yale New Haven Hospital in a study that was recently published. They saw a 60% increase in victimization. In other places, it might be at 40%, but we saw somewhere between 30 and 60% spikes. So really significant impact during COVID. And so there are many hospitals, given these spikes, saying enough is enough, we need to do something. And then they call us to help them stand up a program.
Thank you so much for that. I see we have a question in the Q&A, but I'm going to hold it until all the panelists have spoken, just because I think it applies to everybody. So thank you so much for your presentation.
Thank you. Really
We will
appreciate it.
definitely come back to you during the discussion.
And I will need to jump off. So I just wanted to let you all know that. But thank you for the opportunity to be here.
Okay, excellent. Thank you so much. And we saw you posted your email. Is it okay if people contact you there?
Absolutely.
Okay, absolutely.
Thank you.
All right, thank you. All right, the next up, we will have our next panelist, Josefina Alvarado Mena.
Good afternoon, everybody. Let me just share my screen and we can get started. Thank you. First, I'd like to thank the Reed Scholars for this invitation and for creating the space for this really critical conversation. My name is Josefina Alvarado Mena. I'm the CEO of Safe Passages. And I also grew up, our organization is based in Oakland, California. We serve several cities and do advocacy work throughout the state. However, our home base is Oakland. That is the community in which I grew up. And we currently serve the community in which I grew up. And so that makes this work very personal for me and also very urgent for me and the rest of the organization. The impact of violence on me personally and my family has been tremendous. Growing up in Oakland, it's a community that has been heavily policed. It's also a community that has experienced tremendous amounts of violence over decades. And there was a time in my history growing up where it seemed like we were going to funerals almost every single weekend of young people that were killed. The impact of violence, as so much research has demonstrated on children, youth, and families and communities, is profound. And intergenerational. And despite all of the good work that is going on, we continue to lose young people. And this presentation is dedicated to one of those young people served by Safe Passages. His name was Mario Gonzalez. He was killed at the hands of police in Alameda, one of the Bay Area cities. And just today, the DA's office came out and announced that there would be no charges filed against the police officers involved in this particular case. So if you are inclined, you could look up that story and see just how raw this issue continues to be for so many people across the country. There are two important themes of my presentation that I want to state from the beginning. I want to make sure that people leave the presentation with these two ideas or concepts in their mind. First is that our children and youth are brilliant, and that we must approach this work from an assets-based approach. We must see the strengths of our children, youth, families, and communities as we approach this very, very important work. The second theme is that there are solutions. I think it's very easy to kind of get lost in all of the challenges and the struggles and the data. And sometimes we forget to see that there are solutions and that those solutions can come from the communities themselves. Also very critical is that solutions that are going to be effective and they're going to have long-term impact and address the root causes of violence must engage the communities as partners. So with those two themes, I'd like to start the slide presentation. Safe Passages is a 501c3 nonprofit organization, again, based in Oakland, California. Our mission is to disrupt the cycle of poverty by engaging youth and families to build and drive a continuum of success that supports student success and community development. We were founded actually as part of Robert Woods Johnson's Urban Health Initiative, which was focused on improving health and safety outcomes for children, youth, in urban areas. And we have really taken that charge to heart over the last 25 years of our existence. We envision a community where all young people have the opportunity to realize their full potential. We're based on the premise that access to educational opportunity, health services, and family support should not be dictated by race or socioeconomic status, and that healthy and supported young people are better prepared to learn and succeed. The Robert Wood Johnson initiative really came out of the LA riots. And the whole concept behind the 10-year initiative was to address the root causes of violence. I'm going to turn off my video because I might be having a little bit of a bandwidth issue. Maybe this will help. Our target communities, disadvantaged communities in Alameda County, we deliver services to over 5,000 families, youth, and children across 4 school districts and 23 schools. We're working with populations that are experiencing the highest levels of health disparities, including the highest rates of COVID-19 infections and deaths, hospitalization for asthma, teen birth rates, and hospitalization for assaults among young people. The children that we serve are over 90% on free and reduced lunch. We work with students that score far below proficiency and have high rates of school suspension, dropouts, and truancy. We work in communities with high unemployment and highest rates of violence and community stressors. And these are the same communities that have been hit hardest by the pandemic. Our work is guided by these core principles: social justice, service to the community, systems change, cultural competency, youth development, continuous program improvement, and family and community engagement. And our core functions include direct services, policy and advocacy, innovative program development, incubation, replication, and investing in people, development of human capital. Our initiatives and programs have all been designed to address violence and the root causes of violence within our communities. And we work along the entire continuum of children and youth, beginning in early childhood, and then all the way up through career pathways and economic development. And I'm going to talk a little bit about each one of these strategy areas. Within the early childhood initiative, we begin at birth. We work with families and recruit families from a variety of different backgrounds and in a multitude of languages to participate in this initiative, recognizing the importance of early childhood development and that this is a critical period in terms of brain development and a critical period in terms of mitigating exposure to violence and other social determinants of health. This programming includes infant play groups, parenting workshops that focus on attachment, family literacy, school and success workshops, school readiness, mental health, case management, and community resource linkages, and food distribution programs. We recognize that the family unit is the key unit for a young person throughout their entire lifetime and their life trajectory. And if we can strengthen the family unit, the young person and the family have much better outcomes long-term. And so we must focus on strengthening families to the extent that we can. The next area of our work is based on school-based interventions and schooling services. And we work in schools pre-K all the way up through 12th grade and high school. And these services include academic tutoring and mentoring, extended day learning opportunities, summer learning opportunities, family resource centers, connecting people to public benefits, creating school-based health centers, providing young people with the opportunity to engage in art, and also teaching young people about their history and their culture. And those classes provide students with not just high school credit, but also college credit to get them introduced to higher education. We found that these services are incredibly important, and our young people continue to be very far behind, particularly students of color. And these academic supports are absolutely essential in order to put them on a track so that they can experience some school success and have options by the time they, well, first of all, they have to graduate from high school, but then have some options beyond secondary school. The next area of our work is focused on economic and social justice. And this part of our continuum includes life coaching, case management, mental health, career exploration, internships and jobs, urban arts, food security, and because of the pandemic relief resources, has begun to include emergency rental assistance to address the very fundamental issue of housing and the need for housing stabilization within our communities. Within that strategy area sits the Law and Social Justice Life Coaching Program. This is an intervention that is part of the California Reducing Disparities Project that has been funded by the California Department of Public Health for over 10 years. We have been part of the phase 2 pilot implementation phase, and this initiative has targeted 5 marginalized communities, including African Americans, Latinx, API, Native American, and LGBTQ+ communities. And the goal of the initiative has been to uplift community-defined evidence practices that reduce negative mental health outcomes within these communities, and that focus on addressing toxic stress and trauma that have been experienced by these communities. Our particular project is focused on African American youth and includes these really innovative and important elements. It is a community-defined practice. It is culturally congruent to the African American community. It includes life coaching, case management, trauma-informed practice, career exploration, urban arts, ethnic studies, and has demonstrated improvements in education and mental health outcomes. The strategy has created space for African American young people to learn about their culture, learn about their history, be supported by case managers and life coaches that look like them, have shared life experience, and that have been able to been successful, not just in education, but also in life. And the ability to build relationships, develop coaching strategies, and increase resiliency has proven to be incredibly effective at reducing depression, reducing anxiety, and also improving educational outcomes. So in the study that we have been conducting for the last 3 years, we have demonstrated that 100% of the participants were able to matriculate either 1 grade level or graduate from high school. This is, sad that we have to include this as an outcome, but it is the reality that 100% of our participants are still alive. And that is incredibly profound, but also important as we talk about this work, and also reinforces the urgency of the work that we are doing. I want to talk a little bit about the career pathways and economic development because a really critical part of our work is ensuring that our young people are able to be successful as adults and are able to be self-sufficient. This is also not just important for the individual participant, but important for their family and important for their community. So we have developed career pathways within the organization to be able to provide at least the beginning part of an introduction into the workforce. We have several programs, including AmeriCorps, Vista. We have internship program for social workers, and we have job opportunities in which the young people that we have previously served can come back to their communities and serve as after-school academic instructors, mentors, and engage in community outreach and education. Our youth really need this kind of support in terms of entering the job market, because so many avenues have been closed to them, and they're often overlooked in terms of job opportunities, job training programs, And we have a special emphasis on young people that have been engaged in the juvenile justice system, are at high risk of being systems involved. We also work with foster youth and other systems involved youth. And we just need to create these avenues so our young people have opportunity. I want to talk a little bit more about the family resource centers and the supports that we provide through those vehicles. Again, supporting families is incredibly important. Families are often overlooked, and the assets that families bring to the table are not always valued. The family will be there in the lives, hopefully, of the young person throughout their trajectory. We all will come in and out in the lives of our young people and our children, but the family will be there. And so we must really commit to investing in families. So families are at the center of our work. And we have developed a number of culturally and linguistically appropriate family resource centers that support the African American and the Latino community predominantly, but also other families of color. And they offer a continuum of family support services that address food security, housing stabilization, and housing support, as well as connections to legal services, immigration pathways, and other critical support services. Our approach is based on the Maslow's hierarchy of need. We try to address meeting the basic needs of families first, before engaging families in other educational training opportunities. Often there's this expectation that all families can participate in the education of their children, and all families, of course, want to participate, but not all families have the luxury of doing so. We have found that if we can help families meet the basic needs, then they are better able to participate in supporting their children in their education. And they're better able to support their children. We meet families where they are. Here's just a couple of pieces that I wanted to share with the audience today. A bag of food is more than just a bag of food. It's a way to begin to build relationships with families and to engage families in additional services and opportunities. It's also a way to reinforce the importance of culture. And we say this all the time, culture is health, and culture just builds up the protective factors of our families. And it's important that our strategies are aligned with that. Over the pandemic, there has been a tremendous increase in the need for food security. And between the period of March 2020 and December 2021, we distributed more than 1 million pounds of food directly to our families through our Family Resource Center network. Just an overlay here of the poverty and our work. You'll see that the little gold dots are where we have place-based services and programs, and we are really targeting the communities that are experiencing the most poverty. These are also the communities that experience other disparities and the most violence within our city and county. And a note about the vaccinations. We have been engaged in working directly with our communities to increase the vaccination rates. Our families have been the most disproportionately impacted by COVID rates of infection and also COVID deaths. And so we have been using our infrastructure to support COVID public health information and also vaccinations. We were not involved in this kind of work prior to the pandemic, but we made some pivots to be able to address this really critical need for our communities and to help try to keep pace with vaccination efforts. And just to close, I wanted to bring us back to the two themes that I started this presentation with. The first being, again, the strengths of our children, youth, and families, and the resiliency of them, and the need to build off of those strengths as opposed to looking at the deficits of our communities. And then the second point being that there are solutions and that those solutions can come directly from the communities that we're serving. Those solutions must involve partnership with the communities that we serve. And also that the work has to focus on bringing additional resources to scale up the solutions that work. So thank you, everybody, and happy to answer any questions now or during the Q&A session.
One question, thinking about it, especially with the information that you gave to us about Mario Gonzalez, clearly a horrific situation, but unfortunately is not uncommon. How do you continue to engage the community in this kind of ongoing cycle of hope, loss, mourning, and kind of how that can continue, especially when you're trying to build their own resilience while also resuming and rebuilding some faith in the structures that are supposed to continue to aid people?
Well, one of the ways that we do that is, through our ethnic studies kind of instruction and education, and reminding and teaching our young people and the families to some extent, about our history of struggle and the history of our activism, and why it's important and why it needs to continue. And that, historically change has always taken a long time to happen. And that even when it seems like things are the darkest, that we do have some guiding lights, and that we must continue to invest in our young people. And that, we need to make sure that we create a space for people to grieve, and a space for people to work through their trauma and their grief, but at the same time, continue to build on the assets of our young people, of our communities. It's always been a long fight, but it's a fight that is important for all of us. And we need, more people to be engaged in this fight if we are to make the long-term policy changes and budgetary changes that will create, greater equity within our society. But it is hard. And it is demoralizing, and it's painful. And, we need to acknowledge that, but also find a way to kind of continue to work through that.
Excellent. Thank you so much for your presentation, so much for your answer. I'm certain we will have lots more to discuss a little bit later. And so for our third and final presentation from our panelists, I will hand it over to Dr. Vincent.
All right, good afternoon. I'm so happy to join you all virtually to talk about this topic and to join this amazing panel. And I think you'll notice some overlap in themes that are shared. And in this conference with this audience, I realize this is preaching to the choir a bit, but I think it's always helpful still to take a minute to think about the dissonance between the things we're talking about, the things we're bringing up, the threads in these presentations, and the narrative around what America is. The American dream is one that we have all been exposed to. We stand up saying the Pledge of Allegiance in school, saying this is a place of liberty and justice for all. So there's still, even when we do this work, even when we know it doesn't quite vibe, something that we're up against as we operate in this society and as we try to help educate decision makers, that there is a disconnect between the American dream and what many people in our society actually experience. And Ms. Minia is an exception in that she is from that community and also making decisions. So often there's a disconnect, right, between the decision makers and the people that are there. If you ever go to London, again and again when you're on the subway, it says, mind the gap, this whole thing. There's even like t-shirts about it. And the reason they're so repetitive is because the consequences of not minding the gap are really significant, right? You fall through the gap and bad things happen. And I think that when we're doing this work, when we're talking about these topics, especially when we're interfacing with people in positions of power, like judges or lawmakers, and trying to use our privilege as physicians or healthcare workers to do that, we have to be mindful of the gap they have and bring their attention to that as well. And so you all know this, but the purpose of this slide is really to challenge you that whenever you hear someone talk about mental health disparities, that you counter with the fact that they're all inequities, actually, not just differences, but that these are differences that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. It's not just a, golly gee, that difference is there, that's interesting. There's something you can trace it back to that was a decision that someone made at some point that resulted in the difference that we're seeing. And it's really important to do that, because in the absence of that, the onus for change, or even the idea that it can be changed, gets placed in these fuzzy places, and that change doesn't happen and can't even begin to take place. And we have talked about structural trauma, that's been alluded to as well, but just the definition that I like to use is when society systems and structures, as they are configured and routinely operate, are instruments of harm. So often when we say trauma, when we say violence, we're thinking about things that are aberrant behaviors or one-offs or something that was a deviation from the system or a mistake. But with structural trauma, this is on a Tuesday, how things happen in a given society or a country. And so I'm a child and adolescent psychiatrist. I've worked in public sector children's settings throughout my career, but I've also worked in private settings. And so I have this juxtaposition of what things are like in one zip code of Atlanta, which is where I'm based, versus another, and have always had that. And so an example of structural trauma that I see where I work is the school system, right? So you send children to school, you tell them to work hard, you tell them this is their path to becoming a productive member of society and having a good job when they grow up. And sometimes we send kids to systems that we know actually don't meaningfully prepare them to take those steps, where issues they may have with learning or comprehension are not adequately identified, let alone addressed, where that child's response to the frustration that is, of course, informed by their immaturity and the fact that they don't understand what's going on is phrased as oppositional or willful or defiant or bad, especially if it's already a boy who looks like this, who society's already primed to think of as bad. And rather than school being a place that is a bridge to opportunity, school is a place where they are labeled and routed to the criminal justice system potentially, or even if they don't end up in the criminal justice system, routed on a path that does not position them to take their place in society, to realize their potential, and to be able to see opportunities in the ways that kids on the other side of town do. And for a concrete example, one of the districts where I work, the one that's zoned for the county clinic, for the children who graduate from that school, and they have a 75% graduation rate, only 33% of them are college or career ready at the time of their graduation. So these are children who have stayed out of trouble, not gone to juvie, stayed in class, done the things the adults and the systems and all these things around them told them to do, but at the end of it, only 1 out of 3 are actually ready and prepared for the next step. So mental illness, mental health are often talked about as if it's one or the other, when in reality, it's absolutely a continuum. You know, protective factors, supports, adaptive coping push people toward health, risk factors, stressors, maladaptive coping push folks toward illness. And so much of what makes people sick, so much of what helps people be well, has nothing to do with what happens when they come to see people like me for that 30-minute visit. It has to do with what is happening in their communities, in their homes, whether they have a sense of autonomy and security and safety. And when we're thinking about things like the ability to earn a living, the ability to get an education, the ability to feel as if when you call the police, they'll actually protect you. Those are things that we don't often put into conversations around mental health. But when we think about it more holistically, they're absolutely relevant to how people think, feel, and behave. So thinking about what trauma is, and I really appreciate the first speaker talking about how trauma is trauma. It is that simple, but when it comes to mental health medicine and how we approach it, how we document it, how we talk about it, how we diagnose it, it is far from simple. And there's a lot that we miss. Whose trauma counts? So medicine, just like every other major system in our society, serves some people better than others, and serves other people sometimes in a way that's actually harmful. And one of the manifestations of this is that the trauma that disproportionately impacts marginalized populations isn't given the same attention. And because of that, it's not counted in things like our screening instruments and our diagnostic criteria. So there's a systemic injustice there in how we operate and in whose trauma we elevate and are able to fold into the way that we deliver care and think about the people that we're supposed to be treating. And so we talk about interpersonal trauma and domestic violence. We talk about trauma that happens in the home. We think about structural violence that's happening in this very top-down way from all of these systems. But I'll spend a little bit of time now just thinking about racial trauma and how that manifests for people. So I had the opportunity when I was in general psych training to train at Cambridge under Dr. Judith Herman, who wrote this book, Trauma and Recovery, that is really focused on people who've experienced like domestic violence and incest in their home environment. And she talks about how the trauma is experienced in that sort of setting where it's in the context of a relationship and it's over a period of time and it's something that you can't escape from, is a different kind of injury than trauma that takes place where it's a one-off, where it was a stranger who assaulted you, or where it happened in some foreign country and you were fighting in a war and you come back home. That when something happens repeatedly and when something happens in a way that sort of shapes your experience of the world over a long period of time, it doesn't just change how you see what's around you, it can change how you see yourself. And she wasn't talking about racism or structural trauma or structural racism in that book, but I think that there are parallels there. That when you think about racism, when you think about racial trauma, it is something that is absolutely an inescapable part of American society. And not that it's unique to American society, but that's our focus today. And she says in that book, the developing child's positive sense of self depends on the caregiver's benign use of power. And I would posit that systems such as the educational system, the criminal justice, or the carceral system are supposed to be using their power to help people, to help society develop a positive sense of self. And those systems, when they target members of the community, when they harm members of the community, are going to impact their mental well-being, and they may do so in a way that doesn't look like PTSD as classically defined or discussed. And so there are all these different ways that trauma can manifest, and just keeping in mind the audience, I'm not going to belabor the concept, but trauma is really the lupus of mental health. It can affect every aspect of how people think, feel, and behave, and it can affect it in disparate ways sometimes. So you may have some folks whose response is to shrink, to become smaller, so to try to not get attention. You have some people who may become more reactive and angry, who go through the world with the "I have to get them before they get me" attitude. And so we really can't have conversations about mental well-being or about mental health crises or a lot of these things that are getting a lot of attention if we're not willing to have an honest conversation about trauma and about race-based trauma and about structural trauma. And so bringing it to the healthcare system, and you all are aware of this in a way that some of my audiences that are more judges and attorneys are not, but the system itself, one could argue it's a misnomer, right? We know that rather than the focus being on health, it's often about providers and policies and clinical services and what state Medicaid decides to pay for. That care suggests that services involves meeting the needs of patients, but it's more centered on meeting the needs of providers, and I would say payers and payer systems as well. And system implies that there's this organized, cohesive, connected structure rather than what we know to be a public-private patchwork of hospitals, clinics, private offices, health systems, and all the payers that make up healthcare. And I spend time on this because sometimes in these conversations, the idea is if we can just get them to healthcare instead of criminal justice, that will solve the problem. And we have a lot of in-house work to do in healthcare in order for that to actually meet people's needs. The other thing about mental health care, how we think about trauma, how we talk about trauma is, we have post-traumatic stress disorder, we have adjustment disorder, but we don't really have something that captures when the trauma is not post and when it's severe. When we're talking about things like racial trauma or police-based violence or things that the state is doing that harm families, we don't have a diagnosis or a set of criteria that really neatly captures that. And I would say that that's not an omission or a gap. That is something that has been left out because of the kinds of people that these sorts of traumas are going to be impacting. So we don't have diagnoses like complex PTSD. When we look at the criteria A for PTSD, things like race-based trauma or community violence aren't things that are eligible to count for that first part of it, even if they cause all the other symptoms of it. And there's no recognition at all of racial and structural trauma in it. And even when we go beyond the DSM and beyond diagnosis, if we're looking at questionnaires or things that are used at that mental health criminal justice interface, like actuarial risk assessments or discussions of criminogenic risk factors, they are certainly not race neutral, but they're not framed that way. The people using them don't think about those things. And so there's a way that trauma is undercounted. And as a result of that, the people who are affected by them are disproportionately labeled in higher risk groups and treated more harshly by the system because of it. So when we don't count it in clinic, there are implications for how they're talked about, how they're seen in court. And I've seen this over and over again as someone who is an expert who's looking back at records of people who've seen therapists, counselors, psychiatrists, nurse practitioners, PAs, people, clinicians, providers who know at least some of the traumas this person has been exposed to, but who somehow don't manage to incorporate that into their formulations of the person or in their diagnoses of the person. And instead they get labels like oppositional defiant disorder or antisocial traits or conduct disorder. And when a court sees that, when that's not captured in those records, when the court gets a hold of them, it is ammunition in a different kind of way, ammunition to put this person in the category of being irredeemable or someone we're not going to invest in, or as someone who is a threat to society and not able to be rehabilitated. And so there are very practical implications of racism in diagnosis in terms of what clinicians go in with, but then also in how that happens in the court setting. And I know that the framing for this was really around police violence, but I would say that there is violence throughout the carceral system. The police violence is the component of it that goes viral, but there is deadly violence in the system that takes place every day that does not at all levels. And so what you see is that this racism in diagnosis carries through in the criminal justice system, and you have things like confirmation bias. So if antisocial personality disorder is on that person's chart, if they seem frustrated or upset, it's angry because they're antisocial. It's not, did their nurse get by to give them their meds on time this morning? Oh no, that didn't happen because the facility was on lockdown. Premature closure, so not thinking about other things that could be contributing because you think you already know what the answer is. Bias in these tests that people call objective, but that certainly have elements that are based on racialized criteria. So for instance, things like, has the person been arrested before? Well, if you live on one side of town and you have marijuana on you, there's a different chance of you getting arrested than if you're on the other side of town with marijuana on you. That has nothing to do with who you are as a person or how criminogenic you are. It has to do with how you look and where you live. But something like that can be used in these objective tests and risk assessments in a way that results in Black and brown people being judged more harshly. And then ultimately, of course, in the mental health care system, when we're not thinking about these traumas, when we're labeling people with things that don't account for them, for the mood manifestations, and all the other things that it can do to how people present, people end up with improper treatment. And so what we see is that because of what people are up against, because of what they can't escape and are exposed to on a continual basis, that how they present in clinic and what the driving factors are for that presentation may not be documented in the mental health care system if they are able to get to the system at all. So there are structural barriers that of course disproportionately impact the population that's overrepresented in the criminal justice system. There may be impairing symptoms that get in the way. There may be experience-based mistrust of systems. So sometimes you'll see this termed as cultural mistrust, which again is problematic language that is blaming the victim for a response that makes sense when you put it in context. Surface diagnoses and descriptions and clinician bias, and all of that is informed by failure of recognition of structural and undercounted traumas. I had the opportunity to interview Raymond Santana a few years ago as part of a panel discussion. If you don't recognize him, he's part of what is now known as the Exonerated Five, previously the Central Park Five. And one of the things that he said is that we need all hands on deck, and those numbers at the bottom are the age when he was falsely incarcerated, the number of years he was incarcerated, and then the number of years it took for the civil case to settle after everyone knew his adolescence and his early adulthood had been taken away by the system. And if you're here, I take it that you are interested in being part of the solution and using the platform, the privilege, the knowledge that you have to be part of this. And I would encourage you to think about the power and the privilege you already have. And one of the points that he made is that we don't need everybody to go to law school and be attorneys. These issues are present wherever you are. Start there. And also just wanted to have a quick note about the burden of resilience. And that's an important thing to talk about. We're not going to fix all of society's ills overnight. We do need to think about resilience, but I would encourage you that when you're in these spaces and they're talking about this, if they're only talking about resilience and not also talking about protection and prevention, that you push back against that. Because there is something to be said for who we ask to be resilient and why. And I would posit that that goes back to some of the ideas that we know people have about Black and brown people and their pain tolerance and their humanity. And there's an undercurrent to focusing solely on that that is problematic. And I'll end with a quote by James Baldwin: "Ignorance allied with power is the most ferocious enemy justice can have." And I appreciate you all for spending the time today to think about this issue. And I trust to use your power to be part of moving things in a better direction.
Oh, there we go. All right. Thank you so much, Dr. Vincent, for a fantastic talk. Again, to attendees, please put your questions in the Q&A chat and we'll go from there. But before people give us additional questions, I had one question in response to your talk. You mentioned with trauma and the ways that it shows up, there's a very limited way to kind of diagnose them and what goes on with people. And so this is something that comes from experts, but you yourself are an expert who work with people in multiple different areas. So when it comes to working with people in the clinic versus working with judges and people within the law enforcement system, how do you help them understand this, even though within our profession, we haven't quite fleshed out the language to explain it?
Yeah, and so we don't have the language when it comes to diagnostic criteria and diagnoses, but we absolutely do have the language when it comes to our psychiatric formulations. When we take a biopsychosocial cultural approach, when we describe the person as we should ideally be doing as clinicians, not by just their diagnosis, but by like who they are as a person and these different contributors to their thoughts, feelings, and behaviors. And we know about safety, security, belonging, marginalization, and how those undermine basic things people need for mental well-being. So we know it, we just aren't primed to apply it to traumas that disproportionately impacts marginalized groups, because we're not primed to think about those groups and things that disproportionately impact them.
Excellent. Thank you so much. So I'm going to go to the question and answer area. Crystal Yates submitted a question earlier. I wanted to wait until everybody had a chance to speak to answer it. So it says, when seeking solutions for high law enforcement engagement, what does the panel recommend for mental health professionals? Should they partner with law enforcement as co-responders, or does that exacerbate the problem for those in the community? So I will leave it to our two remaining panelists to address it, whoever feels comfortable first.
All right, I guess I'll go first. You know, I think it's ideally, right, you would not have law enforcement unless you needed to have law enforcement. Practically, we have been structured in a way where that was how we operated. And so on the way to that, we may have more of these hybrid, models. I do think there's a way that there are the structural problems in the system, but there are also within the system people who want to get it right, and are collaborating with them, working with them. We can see things move. So, the purist in me says, of course, cops shouldn't be there. But the practical person in me says, if we can get in the room, if we can get in the ambulance bay, if we go, by all means go, because there's a way that you are able to educate, that you are able to model, and in some cases, quite frankly, that you are able to change people's perspective of a community if you share characteristics of that community, just by being there and being who you are.
I mean, I think it's important to try to prevent those encounters from happening. So the point about investing more in prevention to be able to address, the needs of the individual before this kind of an encounter can happen is absolutely critical. So there's all of that work that should be happening and that investment that should be happening. And when we get to the point of there is a law enforcement encounter, I mean, absolutely, I think we'd have better outcomes if we did have mental health people in that scenario. But it's the mental health person in that scenario cannot affect all of the change that has to happen either. There also needs to be a commitment on the part of law enforcement to having the law enforcement, officials and the officers on the ground understand mental health in a different way. There's very little training of law enforcement in terms of mental health and mental health intervention and prevention. And there are countless ways that the encounters could go differently if everyone had a different understanding about what was happening and they had a different understanding of the value of the people that they were encountering. So in the Mario Gonzalez example, if there was a mental health person that had responded to the scene, I totally believe he would be alive today, because there would have been a much different approach. You would have never, tackled somebody down to the ground and gotten on top of them. You just wouldn't do that. You would have engaged him differently. It was not violent. I mean, that's the case in a lot of these situations. So I think yes, but that's not the only part of this solution.
Excellent. Thank you guys both so much for your answers. We have another question from an anonymous attendee, and it says, can the panelists comment on the best way to address Black and Brown pediatric patients that undergo this degree of constant trauma growing up and that also have chronic disease conditions that may doubly impact their trauma? Some examples they listed were repeated surgeries, frequent medical interventions, ER hospital admissions, and things like that.
Okay, so I'll start. That's a great question, and I think a tough one, right? I think one of the things that you deal with as a person who takes care of kids is just the reality of, when we talk about marginalized groups, we usually don't include children in it, but we absolutely should, right? They are a group that is disenfranchised, that doesn't have a voice, that is chronically underinvested in, whose voices are not heard, who are disproportionately impacted by poverty and violence. Children are a marginalized group. So when you are a pediatrician, you are taking care of a marginalized group and dealing with the ramifications of systems that do not protect or provide for kids. So if it feels like a lot, it's because it is. And I think that's just important to step back and acknowledge. And I tell people, pediatricians and public defenders are my favorite professionals, because they are advocates for the most marginalized people. But to get to your question, we do know that there are things that are protective. So being part of a community, the family's ability to sort of be present and there, having a positive racial identity, those are all things that we know can be helpful. And to the extent possible, one of the things that I encourage people to do is to think about sort of that child as part of a unit and as part of a family. And my experience is that pediatricians are actually better at this than a lot of psychiatrists are. But understanding the supports the mother has, the primary caregiver has, as part of the care for the child. Referrals for her support, her mental health, whatever it is that she needs as part of the care for the child. Because as that person goes, so too will the child. And then the other piece of it is, taking our voice as doctors and using that to help decision makers understand that housing is a health policy, that transportation is a health policy. And sometimes, depending on where you're working, or in the situation you described, even if they are a family with some means, they're not going to be able to march down to the courthouse and help explain this to lawmakers because they have to make their appointments. And so seeing part of our work as healthcare providers as helping these broader structures operate in a way that is more supportive of people's well-being.
I totally agree. And I think that there's very little infrastructure to support like cross-sector approaches. And so when we talk about vulnerable children, they really require a multidisciplinary team of support that includes the family, but there has to be some infrastructure to support some cross-sector support for the child you're describing. That child has probably missed a lot of school. And the school people may not understand the medical challenges of the child. And that could be solved if there was one conversation between the pediatrician and the school principal or the teacher, but there's no infrastructure to support that. And so we need to start thinking about, like, how do we create a wraparound approach that is multidisciplinary and that is supported in a way that builds the capacity of the school personnel, of the family, of even the pediatrician on the medical side, of understanding like all of the different ways in which the different systems are impacting that child. And if we can do that, we improve the outcomes for that child on the health side, on the mental health side, on the educational side, and maybe even on the economic side. But we don't have any infrastructure to support that currently.
And thinking about just another way of looking at the question, and especially going with Dr. Vincent's talk and actually with your talk, Josefina, when it comes to, when we think about ACEs, adverse childhood experiences, things like that, it is very rare that these occur in isolation. And so if you're vulnerable for one thing, unfortunately, those vulnerabilities can run in packs. But as Dr. Vincent said, this can come from a lot of intentional decisions that were made and policies that enacted these things. But when it comes to the idea from the person that asked the question, specifically with Black and Brown youth, a lot of it is we are conditioned to believe that people are supposed to be resilient. And going with Dr. Vincent's point, it doesn't necessarily take us to thinking about protection and prevention. So I think that's something that as advocates, we should definitely lean into when it comes to these things that come up, because it is unfortunate that we're conditioned to believe that certain people are supposed to endure a certain amount of suffering before we step in. One question that I had, kind of going with themes throughout all of the topics that have been discussed. In Fatima's talk, she talked about how it was unexpected that even folks from the law enforcement community would have to deal with the trauma and things that they've experienced going through this. Helena, for your talk, you speak about what the community has to deal with as well. I'm just wondering, how do you kind of encourage people or kind of bring in aspects of self-care and coping for all people who are involved when it comes to just things that surround the ecosystem for vulnerable people?
I mean, I think one thing that's very important to do is to, really internalize this notion of, there's no quick fixes. And so these are complex problems that involve multiple systems, and we have to sustain ourselves. And so the issue of self-care, you might think about it differently if you're thinking that you have to run the whole marathon. It's not just the sprint, you have to run the whole marathon. So you have to train up and you have to stay trained up to be able to continue to work within these systems. The other thing I wanted to say, going back to the last question, is we are also conditioned to stay within our designated roles, within our designated silos. And so if we're going to really implement solutions, to address the complexity of the issues that we're thinking about, we also have to become more comfortable with stepping outside of our roles, stepping outside of our established silos to think about these things differently.
Absolutely agree. And I think sometimes, at least the way medical training is structured, it's very, first you do this, then you do this, then you report to this person, then you do that, right? Like it sort of trains what you're talking about, I think even more so than other sort of professional cultures. And there can be reluctance to, what do I have to say to judges? Or what do I have to say? You have a lot to say, actually. And, as someone who graduated with a class full of doctors, you kind of take that title for granted in some ways, probably. But when you step outside of it, you'll find that people are really interested in what you have to say. And you be, and I'll just speak for myself, like I have been just blown away by the reception I've gotten in, places like Utah. Like, like y'all see me, like y'all want me to talk, you should, but like it works when you go in with that sort of medical mantle. And so it can absolutely be leveraged. It's not something that we are trained to do, but that we are absolutely capable of doing.
I mean, with that comment, I think you guys are both talking about the concept of what is your role in a situation. And I think a lot of times, healthcare for the longest said anything that happens outside of the hospital, that's not our role. But when it looks at the larger kind of context of this supposed commitment to health and wellness and things like that, we get to this concept of responsibility. And so I wonder, for both of you in your work, how do you communicate this concept of responsibility to empower people? Because you all were just talking about how do we empower ourselves, but when it comes to empowering and putting the impetus on systems, on decision makers, how do you kind of start that messaging?
Well, I'm a strong believer in leading by example. And so, I talk about, my own personal narrative, as much as I can, because I want to, demonstrate that you can come back to your community. You can, make a difference in your community. So often, I think for people of color, there's this notion that we have to leave our community to be successful. Like if we leave our community, then we've made it. And so we have to counter that narrative. And demonstrate that you can come back to the community, that you can be successful, that you can have a good life. There's all of these kind of counter messages that we encounter in our professional training and higher education, that we need to, uplift additional voices. And, it starts with our young people. And so it starts with telling our young people about, who they can look up to, and putting those examples in front of them, because that's not part of the common curriculum, our curricula that our kids are exposed to. And so we have to bring that forward. We have to uplift those examples, and we have to inspire our young people to take on that responsibility and understand that, as a collective, we need to improve our outcomes.
Yeah, and I would say on the other end of it, with the people who are not part of the community but making decisions about it, sometimes it's just about showing up. And it's about showing up over and over again until they get used to you and they start like having you on panels and putting you on commissions and things like that. I know it sounds really simple, but a lot of times we haven't structured our career in a way, or the people that we work for haven't structured our position in a way where we're able to show up. But if you can do that, that is half the battle in terms of getting your foot in the door. And the other thing that I would say too is understanding that wins can look different ways, right? And so there are sometimes commissions that say they do one thing and they're not doing that at all. But the fact that this very conservative governor appointed you to it helps you when you're advocating for someone in Alabama, right? And so thinking about just alliance building and credibility and how to be effective, and that a piece of it, like the early piece of it, the sort of basic piece of it that's not complicated at all is showing up. And so I think, if your early career, thinking about how you structure your time, and I'm about to have a transition where I'm going to have to sort of rethink this myself. But one of the things that I decided to do was not work full time for anyone, because I wanted to have a certain amount of control over my time and my voice, so that I could show up. I could decide to shift clinic so I could go to this thing and make that work. It's something we can do. Like I've been doing it for 10 years. Again, it's something that's not necessarily modeled to us as we're going through medical training in these, academic towers. But it's absolutely, again, something that you can do and that can make a difference if you decide to do that.
I think you both referenced kind of I'm going to name it as the friction that can exist between the community and some of these external organizations that attempt to help in their own way, whatever that may mean. Josefina, you mentioned that you have actually come from the community that you're helping now. And Dr. Vincent, you mentioned how that is a rarity when it comes up. I want to just hear from both of you when it comes to these external agencies and things like that. What are some of the misconceptions that they can kind of come in with? And what are some ways that they can kind of take those away so that way the partnership is a bit more appropriate for both parties?
I mean, I think a lot of external entities will come in with a very top-down approach, and an approach where, you know, they're the saviors. And that's the absolute wrong approach, you know, in my experience. I mean, we have to listen to the people that we're trying to serve. And we have to create space for the people that we're serving to be in leadership and decision-making positions. If we don't do that, you know, the implementation of whatever, even if it's the best strategy of in the world, is not going to be very effective because there's no ownership within the community. And so we have to level the playing field in terms of, you know, who's in the conversation, and stop tokenizing the community members. It's not enough to have 1 seat or 2 seats. We have to, you know, really create the space for community to be in leadership and to be in decision-making position, and also to control some of the resources. Right now, you know, it's very uneven. The power dynamic is not equitable. And so we can't expect that these processes or these initiatives are going to create equitable outcomes at the end of it if the power differential is so severe.
And even in thinking about, to sort of continue that thread, thinking about things like grant applications, right? To do work in the communities. Like if you're at the table where people are making these kinds of decisions, are they requiring all these different pieces of paperwork that a well-funded, white-led organization is going to have because they have their lawyer on retainer to do, versus a more grassroots organization? And are those things really absolutely necessary for the work to get done that you're talking about getting done, right? So thinking about bringing the community to the table, but also structural barriers that may be enacted in terms of them being able to access the resources to do the work. One of the early supporters, so I'm a child psychiatry program director in Atlanta. We built it, just kind of had to walk on faith and trust it was going to get funded long-term some kind of way. Our first funder is from a foundation that not only decided, you know, we're going to support the child fellowship at the Black Medical School, but we're going to look at our criteria for grants. We're going to look at who we're awarding them to. We're going to look up at the makeup of their board, right? They decided to change the entire way they operate, but that's what you have to do because those inequities are baked into everything. And so something that looks race neutral is not because resources and access is not race neutral.
I mean,
Absolutely agree. And, you know, just to continue this piece, I mean, we have to think about what is the scaffolding that's needed, right? It's not enough to say, here's this grant opportunity, it's open to everyone, you know, this is your shot. I mean, we have to think about the scaffolding that's needed to build that capacity, to really, you know, give the community and leaders of color in particular, like more access. It's not just enough to say, here's this opportunity. We have to think about what is the scaffolding that's needed to put people in position to really have access.
I mean, one thing is, as we're talking, I'm thinking about the term community. And so generally it's a neutral term, but I feel like we're using it in a way that speaks to a specific group of people in a specific location. And then when it comes to this idea of external organizations being the savior, it's kind of like, okay, but what do people need to be saved from? And so when it comes to people who come with proposals and things like that, from you guys' experience, how essential is it that they're educated about, you know, the history, the policies, the things that enable these problems to exist in the first place? Or as you put it, Dr. Vincent, could it just be a win that comes in a different way if they come in, bring their resources, and allow things to improve?
Well, I think that education is so important, and being at the table, and what I also add to being at the table is having a voice, right? Because they'll put you in the picture, but they don't listen to anything you say, which is still not helpful or useful. And so that is an important piece of it. I think sometimes people may do the things we want them to do for reasons other than the reasons we have. And that's just part of working with different people sometimes. But whenever possible, and again, I think this is something that we can do, that people on this call can do, we can be careful of language, right? So like underserved communities, historically marginalized and under-resourced communities. They're not like, they don't have some service deficit that they need you to come help them. Like they were put behind on purpose, like for the entirety of the country, right? Like, let's talk about it that way instead of, oh, these poor underserved people. Nah, these people who have been wronged, this community that has been wronged. And so we can be part of that. And sometimes it may not be that they're willing to go to a 2-hour webinar about it. But we can, whenever they say disparity, say, no, that's an inequity. And whenever they say underserved, we can reframe it, right? We can be part of doing that.
All right, so we have about 5 minutes left. I wanted to give both of you the space to give any concluding or wrap-up comments before we move on to our next part of the program. Whoever would like to start first.
I can start first. I, again, want to thank the Reede Scholars for the opportunity to be on this panel. Thank the other panelists for the opportunity to be in this conversation with you both. I know one doctor already had to leave, but these conversations are so important because we can't continue to just talk to ourselves. I'm not a doctor, I'm a lawyer. I know this is more of a medical space, but it's important that we really do bring together people from different disciplines and different sectors and work on, these complex issues with a multidisciplinary approach. We've tried to stay in our silos. People have tried to keep us in our silos, right? The power structure likes our silos, but we're not moving the needle in that way. So we really do need to become more comfortable with stepping out of the conversations with just each other, and also stepping out of the roles that we've been trained to be in, because that will begin to help us move the needle forward. And we absolutely have to do it for the Black and Brown children and youth and families that we've been talking about in today's discussion. So I would just leave, the audience with that point.
Amen. I had this, I was helping to plan a conference, and the theme of it was, social and political determinants of mental health. And I wanted to bring in an economist to talk. And the pushback I got, an economist, the theme is social and political, like this is not something a psychiatrist is trained or has the expertise to talk about. We eventually got him in, it went great, but like it was a battle because of what you're talking about, those silos, even when that's what you've named the conference. And, I would, and again, I know I'm preaching to the choir here, but when you're thinking about how you structure your career and your time and why you choose to make the time for this kind of work. If your goal is to plug into the existing system that is giving you the current inequities in how people experience it and in their health, and to extract as much money as you can from that and prestige as you can from that, that's one thing. If your goal is actually for a more healthy society, and for a more equitable society, we got to get out of clinic. We got to go to other conferences. We have to collaborate with attorneys and people from different professions and show up. And yeah, I'll stop there.
Well, thank you both for just your contributions today, for your amazing thoughts and just practical things that the audience can take away. Thank you to our panelists, Fatima, who had to leave earlier today. Thank you for the Reed Scholars and sponsoring organizations for us to really just create this space. I mean, I think a couple of things to take away are definitely that the problems and difficulties that we face are very large. Current systems are set up for us to operate within silos, but the people that we serve don't exist in silos. So sometimes we have to be more flexible. And even though the issues are large and they can be daunting, there are solutions. And I think also as you step outside of those silos, you realize that it's not your sole responsibility, but there's support out there to kind of tackle this very large thing. So I thank you all for your attendance today. At this point, I will turn it over to my colleagues to present the Vision Award. Thank you so much.
Our Vision Award is presented to a person who exemplifies commitment to health equity and supports the Reed Scholars. This year's recipient is Elna Nagasako. Elna serves on our board of directors and has been instrumental on several of our committees this year, especially the development of the research committee. Elna lives in Hawaii and suffers through early morning calls with us and keeps us on track with her project management skills. Her work on our strategic planning task force propelled our organization leaps and bounds over the past few years. Elna, thank you for everything that you do, for your support of Reed Scholars, for your support of me as president and as a friend. The Vision Award reads, "In grateful appreciation for your tireless commitment, dedication, and strong work to establish the Reed Scholars, Inc. research program." Thank you so much, Elna.
Thank you, Mary. I'm so honored to be part of a group like the Reed Scholars with its steadfast commitment to advancing health equity, as inspired, of course, by Dr. Joan Reed. And Mary and Cynthia Hodge, you humble and challenge me with your unwavering belief that the scholars can achieve even more as an organization with increased collaboration, including in the area of research. And of course, I'm inspired by committee members, Franny Polanco-Walters, Denise Williams, and Alexi Boudreau, who they bring their energy and expertise as clinicians, advocates, community partners, and scholars. So I just look forward to everything that is to come as the Reed Scholars continues to develop. And I thank you for this honor.
Thank you so much to all of our panelists, to you and the audience for making this year's event amazing. I would also like to give a special thanks to the other members of the Health Equity Symposium Committee, Cynthia Hodge, Chantel Herbert-McGee, Denise Williams, and Brian Swan. To my executive committee, Nicole Del Castillo and Don Lee, the board of directors, and our virtual assistant, Lanika Portis. Thank you, of course, to Dr. Reed for your vision and your continued support of Reed Scholars, and to the DICP office. Special thank you to Ying, Jackie, and Tom. Hope that you will tune in to Reed Scholars Live throughout the year, and we look forward to seeing you at next year's Health Equity